You will be asked to sit in a chair or lie on an operating table with your arm resting out to the side. The surgeon will use a pen to mark out the important anatomical landmarks on your skin. Local anesthesia is used to numb the wrist and palm. A tight tourniquet is applied to your arm and, in some cases, is slowly wrapped up from your fingers to remove most of the blood from your lower arm, that is, limb exsanguination. This allows the surgeon to operate in a bloodless field, which is essential for a clear view to reduce the risk of median nerve injury. It also helps to keep the local anesthetic agent in the area and is essential if you are having intravenous regional anesthesia. The surgeon makes a straight incision over the palm of your hand in line with your ring finger. The cut extends down to just above the first wrist crease and is sometimes longer if greater exposure is needed. The incision is usually 1.5 inches to 3 inches, that is 4 centimeters to 8 centimeters long. The fat beneath the skin is pulled in either direction with refracture or retractors to expose the underlying sheet-like tissue called the superficial palmar fascia. This is cut through in line with the skin incision and also retracted to either side to expose the underlying transverse carpal ligament. The surgeon passes a blunt, curved clamp under the ligament to protect the nerve and flexor tendons beneath. Using the clamp as a guide, the surgeon carefully cuts the transverse carpal ligament along its length under direct vision. In this way, he can perform the operation. Minimally invasive surgery aims to cut the transverse carpal ligament from within the carpal tunnel, leaving the overlying structures intact. This can be carried out through either 1 or 2 small incisions. In both techniques, the first incision is 0.6, that is 1.5 centimeters wide, and is made at the base of the forearm, just in front of the first wrist crease. The underlying loose tissue is carefully dissected and spread apart to preserve any tiny nerves. A flap, rather than like a trapdoor, is cut into the underlying deep fascia of the forearm to expose the carpal tunnel. Blunt probes are then inserted to gently open up a passage through the tunnel. A combined viewing and cutting device is inserted and advanced down toward the palm, which is in the correct position. The underside of the transverse carpal ligament is easily identified as it is made up of striped bands of collagen. The blade is raised and the device carefully withdrawn to cut through the ligament. 2 or 3 passes are needed to complete the procedure. The device is then reinserted to check that the ligament is fully divided. Finally, the device is inserted in the other direction up toward the forearm and manipulated to cut the lower part of the deep fascia of the forearm, which is connected to the transverse carpal ligament. 2 incision technique. If 2 incisions are used, the second is made parallel to the first in the lower palm. A clear plastic sheath is then passed into the sheet.
It's okay.
One more.
I can do more than that.
I know, but I'm tired.
You're tired? Alright, one more.
A long day. Back to your favorite.